Hello. Today's lecture will address the behavioral objectives for week 4 in the syllabus. Let's begin. Cardiac catheterization. This is a diagnostic procedure which utilizes a radio-opaque catheter, and it is inserted through a peripheral blood vessel into the heart. Once the catheter is in the heart chamber, contrast media is injected and films are taken of the dilution and circulation of the medium. It has 3 purposes. The first is a diagnostic purpose. Here, it will help to diagnose congenital heart defects, and it will be done also before surgical repair. 2, interventional. This is when a catheter is used for therapeutic purposes to alter the heart's anatomy. This can actually help to prevent someone from undergoing a full heart surgery. Number 3, electrophysiology. This is when the catheter with tiny electrodes is inserted, and it will actually record the impulses of the heart directly from the conduction system to evaluate dysrhythmias. And sometimes they will actually destroy the accessory pathways that cause tachyarrhythmias. So what do we do as a nurse before the catheterization is going to take place? Well, we're going to make sure that the physician has explained the procedure, and then the consents are signed, and we can co-sign those. The nurse can answer questions and clarify information. Consider the child's development when explaining the procedure. To reduce the pain of catheter incisions, ELAC cream may be applied topically about 60 minutes prior to, or a buffered lidocaine using a really small little thin 30 gauge needle can also be used and injected intradermally. A complete nursing assessment, including accurate height, is necessary. The height is super important because this is needed so they can have an accurate catheter size. Weight is really important so that the medications utilized can be appropriately calculated. Vital signs and baseline SaO2 is also necessary. Also, we need to do a history of allergic reactions to seafood or latex. This is important knowledge because some of the contrasts used have iodine in it, so we would need to know that prior to the procedure. Monitor for signs and symptoms of infection, such as a severe diaper rash. This could actually be a reason to cancel the procedure until the rash is cleared up. This is necessary, especially if they will be using a femoral access. Assessing and marking the pedal pulses before the procedure is necessary. The presence and quality of the pedal pulses in both feet need to be documented clearly before and after the procedure. They should be NPO anywhere from 4 to 6 hours or longer prior to the procedure. And then, of course, IV fluids to prevent dehydration and hypoglycemia. This is especially important in children with polycythemia. After the catheterization has taken place, this is pretty much similar to most other post-op care, with few exceptions. Initially, the child will be placed on a cardiac monitor and a pulse oximeter for the first few hours. It's very, very important that we monitor for hemorrhage at the catheter site. We also need to monitor the pulses, especially below the catheter site, for equality and symmetry. Note that the distal pulse may be weaker for a couple of hours, but then return to normal. We also need to monitor for color and temperature of the affected extremity. Coolness and blanching may indicate arterial blockage. Vital signs initially will be done every 15 minutes, and we will assess the heart rate for a full minute. We'll be assessing for bradycardia as well as dysrhythmias. Blood pressure, signs and symptoms of bleeding, dressing, we'll be assessing the dressing for bleeding, and we will also be assessing for any kind of hematoma formations. Assessing for intake and output for adequate hydration, hypoglycemia, and then depending on the hospital's policy, the child may need to be on bed rest with the affected extremity straight for 4 to 6 hours for venous access and 6 to 8 hours for arterial access. Please note that a pressure dressing is usually applied. Diet as tolerated. Encourage the child to avoid to eliminate the contrast media. This is why we really want to make sure we're giving them plenty of fluids. If they are wearing a diaper, we want to keep the dressing dry by covering it with a plastic film and sealing the edges with tape. Dressings may be then changed daily for 2 days and then removed. Showering is okay, but no tub baths for several days. School is also okay. We want them to rest and have quiet activities for 3 days and avoid strenuous activities. Observe the site for redness, swelling, drainage, and bleeding. Monitor for a fever, and contact the practitioner if any of these things occur. They can be on a regular diet, and acetaminophen can be utilized in the event that they are having some pain. Please note, if bleeding occurs, this is a critical alert for nurses. You want to apply direct continuous pressure about 1 inch above the percutaneous insertion site to localize pressure where the vessel is actually punctured. Let's talk about the cardiovascular system and some of the changes that occur at birth. So the circulatory changes that occur at birth, basically we have a transition from fetal to pulmonary circulation, which occurs in a few hours. The foraminal valley between the fetus's atrium will close soon after birth. The ductus arteriosus shunts blood to the aorta and to the lungs. This closes multiple hours after birth. If the child has a desaturated blood, which is a low oxygen chronically, the bone marrow is actually going to compensate and will make more RBCs to increase the amount of hemoglobin to carry the oxygen in the blood. This then results in polycythemia. This can then increase the risk for thromboembolisms and then result in a stroke. Therefore, dehydration must be prevented. Normal SaO2 is 95 to 98%. Congestive heart failure. Here, this occurs when the heart can no longer meet the baby's circulatory or metabolic needs. This is often due to congenital defects. Usually it's a combination of right and left-sided failure. Right-sided failure, often we see low extremity edema and hepatosplenomegaly. Left-sided failure, we're going to hear crackles in the lungs. Signs and symptoms based on the function. So first, we're going to talk about impaired myocardial function. What signs and symptoms of CHF will we see with this problem? Tachycardia, inappropriate sweating, decreased urine output, fatigue, weakness, restlessness, anorexia. They will be pale. Their extremities will be cool. They will have weak peripheral pulses, a decreased blood pressure, a galloping heart rhythm, and they may even, in time, develop cardiomegaly. What signs and symptoms will we see in terms of pulmonary congestion? Here we would see tachypnea, dyspnea, retractions, especially in our infants that have that soft rib cage, nasal flaring, exercise intolerance, orthopnea, cough, hoarseness, cyanosis, wheezing, and grunting. Signs and symptoms for systemic venous congestion. Here we could see weight gain, hepatomegaly, peripheral edema, especially around the eyes, ascites, and neck vein distension, which is typically something we'll see more in children. Also, an increase of weight of 50 grams over a 24-hour period is considered excessive for an infant. An increased weight of 200 grams in a 24-hour period is considered excessive weight gain in children. Diagnosis. A chest x-ray will show cardiomegaly. An ECG will show ventricular hypertrophy. What are the goals of treatment? We want to improve the cardiac function by increasing contractility and decreasing the afterload. We're going to remove accumulated fluid and sodium. This will help to decrease the preload. We're going to decrease the cardiac demands. And lastly, improve tissue oxygenation and decrease oxygen consumption. So, improving cardiac function. The medication that is most commonly given is digoxin, and this will improve the heart's ability to contract. It slows and strengthens the heartbeat. We also want to monitor for signs and symptoms of toxicity. These are nausea, vomiting, diarrhea, headache, bradycardia, and visual disturbances like halos. You might see small children and infants rubbing their eyes because they are seeing these halos. You want to monitor the levels 6 to 8 hours after the dose is given, and the therapeutic range is 0.8 to 2.0 micrograms per liter. Check the apical heart rate for 1 full minute. If the heart rate is less than 90 to 100 in young children and infants, that is a problem and you must call the physician. If it is less than 70 in older children and less than 60 in adolescents, you want to hold the medication and again, call the doctor. Monitor the potassium levels. If it is low, again, call the physician because a low potassium level can result in an increased risk of digoxin toxicity. ACE inhibitors, they are also utilized. These help to cause vasodilation, resulting in a decreased pulmonary and systemic vascular resistance, a decrease in the blood pressure, and a reduction in the afterload. Some side effects here are hypotension, renal dysfunction, and a cough. Beta blockers, specifically carvedilol, decreases the heart rate and the blood pressure. It can also cause vasodilation. So some of the side effects here will be dizziness, headache, and hypotension. How are we going to get rid of that excess fluid? Diuretics are utilized to get rid of the extra water and salt. Most commonly, we will see Lasix or furosemide given. This blocks the resorption of sodium and water in the proximal renal tubules and interferes with resorption of sodium. This is the drug of choice in children with congestive heart failure. Please know that it is not a potassium-sparing diuretic, therefore it may cause a low potassium level. Make sure we check the weight daily. We do a good intake and output. We want to encourage foods high in potassium, or they may be getting a potassium supplement. Side effects of this medication include nausea, vomiting, diarrhea, ototoxicity, hypokalemia, dermatitis, and postural hypotension. Chlorothiazide. This diuretic acts directly on distal tubules to decrease sodium, water, potassium, chloride, and bicarbonate absorption. This may be given in alternate days to allow for reabsorption of potassium. Side effects include nausea, weakness, dizziness, paresthesia, muscle cramps, skin eruptions, hypokalemia, and acidosis. Spironolactone. This blocks the action of aldosterone. This has a potassium-sparing effect. This is a potassium-sparing diuretic. Some side effects with this medication include skin rash, drowsiness, ataxia, hyperkalemia, and here you usually do not give potassium supplements. The next goal, decrease cardiac demand. Here you're going to want to encourage bed rest and quiet activities for the children. Maintain normal body temperature, treat infection, keep them in a high Fowler's or semi-high Fowler's position. Medication may be used to sedate an irritable child. You want to encourage rest and decrease the environmental stimuli. They may even need a high-calorie formula if the child is not drinking the recommended amount within a 30-minute period of time. Improve tissue oxygenation. Here you will be doing that by administering cool, humidified oxygen as necessary. In general, what are we doing as a nurse? Want to make sure that the patient is well oxygenated and therefore administering oxygen with humidification as needed, encouraging rest, making sure they're on a low sodium diet, strict intake and output. They may even be on a fluid restriction. Parents should monitor the output and daily weight, weighing the child at the same time every day. When the patient's in the hospital, we also need to weigh the child every day and maintain strict intake and output. If there's a ascites measuring the abdominal girth daily, keep the head of bed elevated to ease respiratory difficulty. Ideally, it is over 45 degrees when we are feeding the child, and we don't want to feed them longer than 30 minutes due to tiring. You'll notice that the child is starting to get tired. This is for your infants, when you notice that they're starting to raise their eyebrows and wrinkling their forehead as they are drinking their bottles or being breastfed. The most common concern for parents is feeding difficulty. We want to maintain the skin by turning them every 2 hours because they may have edema, and this can increase issues with skin breakdown. They need adequate nutrition, and because, as I said, they can fatigue very easily. If they're not able to consume the amount of milliliters they need within 30 minutes, they may need to be NG tube fed. We want to foster development with appropriate toys, provide emotional support, encourage the family to share their anxieties and fears, and then give information and refer them to the appropriate support groups. If the CHF is caused by a cardiac defect, the surgery performed actually may need to be done earlier than originally planned. Please refer to the care plan in your textbook for everything that you need to know regarding congestive heart failure. As I mentioned before, patients are often given digoxin when they have CHF. Here is some patient teaching information that would be really important for the parents to have for children that are receiving digoxin. So 1, give digoxin at regular intervals, usually every 12 hours, such as 8 a.m. to 8 p.m. Plan the time so that the drug is given an hour before or 2 hours after feedings. Use a calendar to mark off each dose that is given, and make sure that you post a reminder, such as a sign on the refrigerator, or you may even put an alarm in your cell phone so that you do not forget to give this medication. Remember, we give it every 12 hours, and you cannot forget this medication. You want to have the prescription refilled before the medication is completely used. Administer the drug carefully by slowly directing it on the side and the back of the mouth. Do not mix it with other foods or fluids, since refusal to consume these can result in an inaccurate intake of the medication. If the child has teeth, give water after administering the medication, because basically this has a lot of sugar in it, and we don't want to damage the teeth. So some people even brush the teeth because you want to prevent issues with tooth decay from the sweetened liquid medication. If a dose is missed and more than 4 hours has elapsed, withhold the dose and give the next dose at the regular time. If less than 4 hours has elapsed, then give the missed dose. If the child vomits, do not give a second dose. Remember, that could possibly be a sign of toxicity. If more than 2 consecutive doses have been missed, call the doctor. Do not increase or double the dose for missed doses. If a child becomes ill, notify the doctor immediately. Keep digoxin in a safe place, preferably in a locked cabinet. In case of an accidental overdose of digoxin, call the nearest poison control center immediately. The number is usually listed in the front of the telephone directory, but you can also Google it for where you live and put that in your telephone, and you should have that available to you at all times in case of an event of poisoning, not just with digoxin, but in anything. Infants rarely need more than 1 milliliter of digoxin, and know that 1 milliliter equals about 15, well, not about, it is 50 micrograms in 1 dose. So know that if you see more than this amount that you're going to be giving, you may want to double check your math or speak with a physician to make sure you are indeed giving a safe, accurate dose. Heart defects. So heart defects can be categorized in multiple different ways. We used to categorize them according to acyanotic and cyanotic defects, but now we Now we classify them according to the direction of the blood flow. So the first classification says increased pulmonary blood flow. And the defects that we see here are atrial septal defect, ventricular septal defect, patent ductus arteriosus. Secondly, we have obstructive blood flow. This is coarctation of the aorta. Thirdly, we have decreased pulmonary blood flow. Tetralogy of Fallot is the condition will be covered here. And then lastly, we have mixed blood flow. Here we'll be covering transposition of the great vessels and hypoplastic left heart syndrome. Remember, normal blood flow of the newborn infant is the blood will come from the superior and inferior vena cava to the right atrium. It then flows to the right ventricle. It goes through the pulmonary artery to the lungs. Then it goes through the pulmonary vein to the left atrium, through to the left ventricle, and out the aorta to the rest of the body. Atrial septal defect. This is an abnormal opening between the right and left atrium. There is a left to right shunting of the blood because of the higher pressure on the left side of the heart. So this increases the pulmonary blood flow. Know that this may close spontaneously. Signs and symptoms. Often it is asymptomatic until school age. CHF may develop. Frequently they will have a systolic murmur. Surgical treatment. They do a surgical Dacron patch when the child is of school age typically. Ventricular septal defect. This is an abnormal opening between the right and the left ventricles. This also may close during the first year of life. Again, there is a right to left shunting of the blood because of the higher pressure on the left side of the heart. So this increases the pulmonary blood flow. In this case, signs and symptoms, CHF is common. You will have a systolic murmur, and they are at a high risk for bacterial endocarditis. Diagnosis, they will do an echo if shunting is present, a chest x-ray, and an ECG. Often the ECG will reveal left ventricular hypertrophy, and they may do a cardiac catheterization when preparing for surgery. Treatment, they may do a patch, and then basically if the child is a failure to thrive, this is typically the procedure of choice in general. Palliative treatment is not usually done. And palliative treatment includes the pulmonary artery banding to decrease the blood flow with severe CHF. But typically we're going to do that surgical patch. That is the procedure of choice. PDA. This is an open passage between the pulmonary artery and the aorta caused by persistent fetal circulation. So typically this is the one that closes within a few hours after birth. Here again, it's considered a left to right shunt because the blood shunts from the aorta across the open duct to the pulmonary artery. Signs and symptoms. They may be asymptomatic or they can even develop, again, CHF. They will have a machine-like murmur. They can have widened pulse pressure and bounding pulses. Diagnosis, chest x-ray and ECG, and again, you might see left ventricular hypertrophy. Initially, if the child is a preemie, the treatment may include indomethacin, and this helps to stimulate the closure of that patent ductus arteriosus. Surgical treatment can include ligating the ductus, although now more commonly, they will do a cardiac catheterization and place a coil into the ductus to occlude the patent ductus arteriosus. Excuse me. Coarctation of the aorta. Here the aorta, close to the insertion of the ductus arteriosus, is narrowed. This results in an increased pressure proximal to the defect, which is the head and the upper extremities, and a decreased pressure distal to the defect, which is the body and the lower extremities. Signs and symptoms here: high blood pressure and bounding pulses in the upper extremities, and then low blood pressure and a decreased or weak pulses, and they can even be cool on the lower extremities. They may develop CHF within the first 3 months of life. They often come into the emergency room extremely ill and even close to death. Older children can experience dizziness, headache, nosebleeds, pain, and weakness in the lower extremities after exercise. Diagnosis: the ECG will reveal a left ventricular hypertrophy. The MRI will show the narrowed aorta. A chest x-ray may show lung congestion and an aortic dent. Treatment: again, they can do a cardiac catheterization and do a balloon angioplasty to help widen that narrow pathway. Surgically, if this is not successful, then they will remove the narrowed part and then re-anastomose the ends together. If this is necessary, this is typically done within the first 2 years of life. This child needs to be followed up long-term with a cardiologist, and you need to monitor for high blood pressure. Tetralogy of Fallot. This is a cyanotic defect and actually has 4 defects present. One is a ventricular septal defect. A pulmonic stenosis is another problem, which is a narrowing at or beneath the pulmonary valve. Third, you have an overriding aorta, which lies over the ventricular septal defect, and a right ventricular hypertrophy. Generally, there is a right to left shunting of the blood, but if the systemic resistance is higher than the pulmonary, then it will be a left to right, but more commonly we see right to left. So as the ductus arteriosus closes, the infant will become more hypoxic and more cyanotic. The pulmonary stenosis decreases the blood flow to the lungs, and it really is the degree of stenosis that determines the severity of the signs and symptoms. Signs and symptoms can include polycythemia, clubbing of the nails, exercise intolerance, poor growth, systolic murmur, hypoxic spells. We also call these TET spells or blue spells, and squatting. Signs and symptoms can get worse as the infant gets older. Hypoxic spells may be preceded by crying, exercising, feeding, and defecating. Polycythemia can cause thromboembolisms resulting in CVAs. So here we need to assess for dizziness, headache, irritability, and paralysis, and all those other signs and symptoms of strokes. Diagnosis: a chest x-ray will reveal a boot-shaped heart due to the right ventricular hypertrophy. An echo may be done, and here they will see the VSD. Cardiac catheterization is typically done prior to surgery to fully locate and identify all of the defects. Treatment: when the child has a cyanotic spell or a TET spell, here they are turning blue because of a decreased blood flow to the lungs and an increase in the right to left shunting. The first thing you want to do as a nurse is place this child in a knee, chest, or squatting position. This relieves the shortness of breath and decreases the cardiac output. Calm the child, give them oxygen, and also, if it's ordered, and it usually will be, you will give them morphine and or Inderal, which helps to decrease the spasms. Treatment: if the infant cannot undergo corrective surgery, initially they may do palliative surgery. There's a wide variety of surgeries that can take place, and there's a table in your textbook that refers to all of the different kinds of surgeries that you can see. Full correction occurs within the first year of life, typically. Monitor for CHF because it may occur after surgery, and again, they need to have long-term follow-up with a cardiologist. Transposition of the great vessels. Here, remember normal blood flow. The pulmonary arteries carry the venous blood flow from the right ventricles to the lungs, and then the aorta carries the oxygenated blood from the left ventricle to the body. In transposition of the great vessels, these are reversed. The pulmonary artery is connected to the left ventricle, and the aorta is connected to the right ventricle. In order for this child to live, they must have a septal defect, a patent foramen ovale, and a patent ductus arteriosus. Signs and symptoms. When they are born, they often are cyanotic, and they do not respond to oxygen. They may be very, very depressed in terms of their respiratory ability. CHF can occur over a few days. They look normal when they're born, except they are blue, and they tend to be very slow feeders. Diagnosis: the chest x-ray reveals a classic egg-shaped heart with a narrow superior mediastinum. Echo will actually show the positions of the arteries arising from the ventricles, and that may be visible. Initial treatment includes PGE1 to maintain an open ductus arteriosus. This increases blood mixing to increase the SaO2 to 75%, and this also will help to maintain cardiac output. Some of the side effects of the PGE1 is cutaneous vasodilation, decreased or increased heart rate, decreased blood pressure, increased temperature, apnea, and seizure activity. This is given until surgery is performed. During a cardiac catheterization, a Rashkin procedure can be done, which will open up a hole in the septum between the atrium to, again, really increase that blood mixing. Surgery of choice is an arterial switch procedure, which is done as early as they possibly can do, typically the first few weeks of life. And here they are switching the places of the pulmonary artery and the aorta and then reanastomose them so they are in their proper position. Problems occur if a narrowing occurs at the anastomosis site. Something that you may see done in the past are mustard and sending procedures. And this actually creates a tunnel inside the atria and redirects the proper blood flow for better oxygenation. This also has been called an intraatrial baffle repair. Lastly is the hypoplastic left heart syndrome. Here, this is an underdevelopment of the left side of the heart resulting in a hypoplastic left ventricle and aortic atresia. Most blood from the left atrium flows across from the patent foramen ovale to the right atrium, to the right ventricle, and out the pulmonary artery. The descending aorta receives the blood from the ductus arteriosus, supplying some systemic blood flow. So here, with the pathophysiology, what happens is an ASD, or a patent foramen ovale, allows the saturated blood from the left atrium to mix with the desaturated blood from the right ventricle and to flow through the right ventricle and out into the pulmonary artery. From the pulmonary artery, the blood flows to the lungs and through the ductus arteriosus into the aorta and out of the body. The amount of blood flow to the pulmonary and systemic circulations depends on the relationship between the pulmonary and the systemic vascular resistance. The coronary and cerebral vessels receive blood by retrograde flow through the hypoplastic ascending aorta. Clinical manifestations. The patient has mild cyanosis and signs of heart failure until the ductus arteriosus closes, and then a progressive deterioration with cyanosis and decreased cardio output occurs, leading to cardiovascular collapse. This condition is usually fatal in the first months of life unless they do have surgery. Therapeutic management. Neonatals require stabilization with mechanical ventilation and inotropic support preoperatively. A PGE1 infusion is needed to maintain ductal patency and ensure adequate systemic blood flow. Surgical treatment. A multiple stage approach is utilized. And as I said before, there are a wide variety of surgical procedures that are listed in the box in your textbook, so please refer to those. Know that post-op complications include an imbalance of systemic and pulmonary blood flow, bleeding, low cardiac output, persistent heart failure. Know that a new modification of the first stage of the repair is the use of the right ventricle to pulmonary artery, and they do a holographed conduit instead of a shunt to supply pulmonary blood flow. They do a few more stages. Know also that transplantation, a heart transplant in the newborn period is another option for these infants. Problems here include a lack of organs, problems with organ rejection, long-term problems with chronic immunosuppression and infection. Prognosis. For the first stage repair, the survival rate varies widely in different centers, but it has about a 10% mortality rate. There's also a risk of mortality in between the surgical procedures. After, the mortality rate for the last 2 operations is less than 5%. In general, post-op care. After surgery, the patient will go to the ICU. They are intubated on a ventilator until they're weaned in multiple hours. You will be checking vital signs, pain, signs and symptoms of dysrhythmias, hemorrhage, infection, tissue perfusion, breath sounds, bowel sounds, intake and output, monitoring for renal function, making sure that their output is more than 1 milliliter per kilogram an hour. If they're over 3 years of age, once they're extubated, they can be taught to use an insonispirometer. If they're less than 3 years of age, they may have chest physiotherapy done. They will be on prophylactic antibiotics. The diet is as tolerated. And yes, they will have chest tubes, and you need to monitor these for functioning and drainage. Typically, the most drainage occurs during the first 12 to 24 hours. There is a problem if the drainage is 3 milliliters per kilogram an hour times 3 hours, or 5 to 10 milliliters of blood in any 1 hour, which can indicate hemorrhage as well as bright red blood in the container. Often for the first at least 2 days, they will be on IV narcotic pain management. For the cyanotic defects, typically they will be on the PGE1. They need to have multiple IVs patent. They will be using antibiotics prophylactically throughout their lives to prevent bacterial endocarditis. If the child has any issues with a low fever, malaise, fatigues that's lasting longer than 2 months, and it's if the fatigue lasts longer, I beg your pardon, occurs 2 months or less prior to surgery or high-risk procedures. So then if any of these things occur, you want to call the physician. So the fatigue for 2 months or less prior to surgery, any kind of high-risk procedures that the patient is going to have. So let's say they're going to the dentist for a cleaning, that would be a time to call the doctor. Also, if they have a fever and malaise. Discharge teaching. Follow up with the pediatrician and the cardiologist. Get all shots, including the flu shot and the pneumovac vaccine. They should have fluoride treatments. And after surgery, typically we want quiet activity for 3 weeks. They can resume regular activity after 6 weeks post-op. Stay away from large crowds 4 to 6 weeks post-op, and then call the doctor again if they have fever, vomiting, diarrhea, or poor feeding. Encourage the parents not to be overprotective, because this child's health after surgery should usually be significantly improved. And so we want the family to recognize this. Often, though, the repairs may not be complete and they may still need to take medications. So know that post-operatively, the parents need to understand the medication regime, because it may be different than preoperatively. Antibiotics prophylactically need to be given prior to all dental visits, and if they're having any kind of invasive GI, GU, or respiratory procedures, as well as a tonsil and adenoid removal. Usually they give amoxicillin or clindamycin about an hour before and then again after the procedures. Next, we will talk about 2 conditions that affect the cardiovascular system: rheumatic fever and Kawasaki's disease. So what is rheumatic fever? Rheumatic fever is a poorly understood inflammatory disease that occurs after infection with a group A beta hemolytic strep condition. It's usually streptococcal pharyngitis. Pathophysiology. There's strong evidence that supports a relationship between upper respiratory infections with the group A streptococcus and the subsequent development of rheumatic fever. It typically occurs within 2 to 6 weeks. Acute rheumatic fever is a result of an exaggerated immune response to a bacteria in the patient. It occurs most often in late school-age children or adolescents and is rare in adults. It is a self-limited illness that involves the joint, skin, brain, serous surfaces, and heart. Cardiac valve damage, and this is referred to as rheumatic heart disease, is the most significant complication of rheumatic fever. More often, the mitral valve is affected. Rheumatic heart disease can occur in up to 50% of people with rheumatic fever. Some sources say that the mitral valve is affected more in the women and the aortic valve is more often affected in men. Clinical signs and symptoms. Here, the American Heart Association has identified major and minor criteria using a modified Jones criteria. To make a diagnosis, you need evidence of a previous strep infection and 2 major Jones criteria, or 1 major and 2 minor Jones criteria. So the major manifestations here include carditis, polyarthritis, erythema marginatum, chorea, subcutaneous nodes, and then the minor manifestations include prolonged PR intervals, elevated acute phase reactants, such as your CRP, ESR, and then clinical findings would include arthralgia and fever. Supporting evidence of an antecedent to group A streptococcal infection include positive throat culture or a rapid streptococcal antigen test, and or an elevated or rising anti-streptolysin O titer. Diagnostic evaluation. The best standardized test is the elevated or rising ASO titer, which occurs in 80% of people. The elevated acute phase reactants like your ESR and your C-reactive protein are also necessary and important part of the diagnostic evaluation. Treatment. The goals of medical management are the eradication of the strep, prevention of permanent cardiac damage, palliation of other symptoms, and prevention of recurrences of rheumatic fever. Penicillin is the drug of choice with erythromycin as a substitute if people have an allergy to penicillin. Salicylates are also used to control the inflammatory process, especially in the joints, and it can be used to reduce the fever and discomfort. Bed rest is recommended during the acute febrile phase, but it does not need to be strict. Prophylactic treatment against recurrence of rheumatic fever is started after the acute therapy and involves monthly injections of benzathine penicillin or 2 daily doses of oral penicillin or 1 daily dose of sulfadiazine. The duration of the long-term prophylaxis is uncertain, but they will typically be 5 years since the last episode or 21 years of age will be how long that they take the prophylaxis. So if they have an episode, they will be taking the medication for at least 5 years or until they are 21. But it may continue as late as the age of 40, and it can be taken indefinitely depending on the risk. They will be on this prophylactic antibiotic longer if they have cardiac involvement. Nursing care management. The objectives of nursing care for the child with rheumatic fever are to encourage compliance with the medication regime, facilitate recovery from the illness, provide emotional support, and prevent any further problems because of the disease. Parents are instructed to provide rest and adequate nutrition during the early period of the illness. After the febrile state is over, the child can resume moderate activity. If carditis is present, the family must be aware of any activity restrictions, and they may need help in choosing less strenuous activities for these patients. Compliance with the prophylactic treatment is very, very crucial, and parents need to know how to manage the child's medication regime. Next is Kawasaki's disease. This is a self-limiting disease that lasts about 12 days without treatment, but know that 25% may develop coronary aneurysms or dilations that can cause heart attacks and dysrhythmias or sudden death. It has a mortality rate of less than 0.17%. It is a multi-system disorder involving a rare form of acute systemic vasculitis. There are 3 phases of the disease. But first we're going to talk about the diagnostic test. Know that there is no definitive diagnostic test, but we do see an increase in the white blood cell count, elevated platelet, elevated ESR, and C-reactive protein. They must check the EKG if they have a fever for 5 days, but less than the 4 findings. So what will we see in terms of assessment? The acute phase 1, a fever of more than 102.2 lasting more than 5 days that is unresponsive to antipyretics and antibiotic, and 4 or more of the following: bilateral conjunctivitis, which is they have like these severely red swollen eyes. They are not painful, and they also do not have pus or draining. They're just very red. They can have dry, swollen, crusted, and fissured lips that bleed easily, and a strawberry tongue. Red oral mucosa, red swelling of the hands and feet, erythema, lymphadenopathy greater than 1.5 centimeters in the neck. Here, it's a condition that causes unilateral swollen glands, and it can be caused by infection or cancer. And then a diffuse, non-blistering red rash on the trunk of the body. Phase 2 signs and symptoms: the fever diminishes. They may be irritable and anorexic. There's a desquamation or a peeling of the hands and feet. They may have arthritis and arthralgia, thrombosis and hypercoagulability of the cardiovascular manifestations. You can see panvasculitis of the coronary arteries and formations of aneurysms. So it is very important that we are monitoring for any kinds of issues with stroke or aneurysms. Inflammation and thrombosis can lead to stenosis or obstruction. Phase 3. Here we have a drop in the ESR and diminishing signs and symptoms of the inflammation. So what do we need to do as a nurse? So their problems are they're high risk for injury, hyperthermia, and high risk for alteration in home maintenance. Interventions. These patients also get a high dose of aspirin, 80 to 100 milligrams per kilograms a day in 4 divided doses while they have an elevated temperature. And then it may continue at 3 to 5 milligrams per kilogram until their ESR and platelets are within normal. This can be usually around 6 to 8 weeks. But if the patient has cardiac issues because of the Kawasaki's disease, then they may be on the aspirin indefinitely. Note that it does help pain, fever, and inflammation. Gamma globulin IVIG is usually given 2 grams per kilogram, 1 dose over 8 to 12 hours as ordered, because this does help to reduce the risk of coronary artery lesions and aneurysms. But this must be given within the first 10 days of illness to decrease the inflammation. Note that sometimes they do need additional doses if the child continues to have a fever. Remember, this medication, IVIG, needs to be started within 10 days of the fever, so there is a time clock for this medication. Nursing management: promote comfort, small frequent meals, passive range of motion to the extremities, cool baths, gentle oral care, encourage fluids, monitoring for those complications like aneurysms, and monitoring for issues with the side effects for aspirin therapy, things like bleeding and GI upset, also monitoring for side effects of IVIG therapy like malaise, headache, nausea, vomiting, elevated blood pressure, facial flushing, tightness in the chest. Live virus vaccines must be deferred for 11 months after receiving IVIG. Parents need to be taught to monitor the temperature and then monitor the eyes also for conjunctivitis. Child and family education. So the family needs to be taught safe administration of the aspirin. They definitely need a flu vaccine. If the child gets the flu or the chicken pox, they will need to stop taking the aspirin, because remember, aspirin can increase issues with Reye syndrome. Also, they may want to defer the varicella vaccine, so have them consult their physician regarding this. Teach the parents to keep the skin clean and avoid soaps and lotions, because we don't want their skin to become dry and cracked. Offer liquids that are high in calories and low in acids, that way it doesn't hurt their sore mouth. A low cholesterol diet. Call the physician of the child if he refuses to walk. You want to make follow-up appointments 1 week after discharge. Monitor the temperature in the morning and the PM prior to giving the aspirin. For patients that are high risk for cardiac disease, they will be on antiplatelet therapy, like the aspirin. So they should not be participating in contact sports because of the risk of bleeding, and they should have regular EKGs. Patients that are low risk for cardiac disease, they need to have assessments and counseling for cardiovascular risks at least every 3 to 5 years. Ideally, the client recovers without serious complications, and the parents describe temperature control measures. Typically, full recovery will occur in people that don't get heart problems within the first 4 to 8 weeks. Next, we will talk about communicable diseases. The first communicable disease we're going to discuss is rubeola, also called measles. This is the 7-day measles. This has an airborne transmission and incubation of 10 to 20 days, and communicability is several days before the rash to 5 days after the rash. Signs and symptoms include initially a high fever, lethargy, cough, coryza, and conjunctivitis. These are known as the 3 C's of measles. Flu-like symptoms, Koplik spots, which are these bluish-white spots in a reddened circumference in the mouth. Acutely, they will have a red flat rash that appears about 3 to 4 days after the onset of the symptoms and lasts about a week, thus 7-day measles. Typically begins behind the ears, spreads to the face and trunk and extremities. Nursing management. The child must be placed in isolation until day 5 of the rash. We'll manage the temperature, keep the room dim. A vaporizer may improve respiratory secretions, petrolatum around the nares, keeping the head of the bed elevated to ease breathing, cool liquids, small frequent meals of soft mashed foods, anti-itch medications. You don't want to put soap on the skin, use soft blankets, and chest physiotherapy as needed. Vitamin A, high doses actually, have been shown to reduce the morbidity and mortality in children that get rubeola. Rubella, also called the German measles or the 3-day measles, this has a transmission with droplets, an incubation period of 2 to 3 weeks, and you are communicable 2 weeks before to 5 days after the onset of the rash. Here, signs and symptoms include a low-grade temperature, headache, sore throat, and cough. They develop a flat red rash that begins on the face and spreads to the rest of the body. Here, the rash lasts 3 days, again, the 3-day measles. It disappears in the same order of its appearance. Nursing management, again, managing the temperature. A vaporizer may improve the respiratory secretions, having the head of the bed elevated, cool liquids, small frequent meals of soft mashed foods, anti-itch meds, not putting soap on the skin, using soft blankets, and CPT as needed. Avoid contact with pregnant women. Remember, this is one of the torch issues that can cause intrauterine growth retardation. Parotitis, also called mumps. Here the transmission is droplet or direct contact, an incubation of 2 to 3 weeks. The communicability is 1 week before and 1 week after parotid gland swelling. Initially, signs and symptoms include fever, headache, earache that worsens with chewing. And then acutely, they can have swelling of the parotid gland that reaches its maximum size in 1 to 3 days. So as a nurse, what are we going to do here? Manage the temperature, cool liquids, small frequent meals of soft mashed foods. You want to avoid sour foods because that can actually increase pain of the parotid gland. Avoiding citrus, spicy foods, candies that increase salivary flow, again, because these will increase the salivary flow and increase pain. You can apply hot and cold compresses to the parotid glands. If the child has a fever, use the cold compresses. Varicella, also called chickenpox. Here, this has a direct contact and it is airborne. Incubation is 2 to 3 weeks, and communicability, it can be contagious actually a few days before the rash develops to 6 days after the first lesions crust over. Typically, we want all of the lesions that are present to be crusted before we let the child go back to school. So they need to be crusted. They don't need to be gone, but they need to no longer be weepy. Signs and symptoms. Initially, they will have a mild fever, malaise. Acutely, they will have a very highly itchy rash that progresses from macules to vesicles to crust. Eruptions last up to 5 days, and lesions of all types can be present at one time. As a nurse, what can we do? Giving acyclovir can actually help to lessen the severity. They also can give IVIG or VZIG, which is the varicella zoster immunoglobulin, can be given to children that are high risk. Non-aspirin antipyretics can be utilized. Do not give aspirin. Remember, this is a problem that giving aspirin to children with the flu, they can basically develop Reye's syndrome, and that's definitely not a good thing. Calamine lotion, topically, oral antihistamines, oral and aveeno baths. Keep the nails short because we don't want them to scratch the vesicles because, or even the crest, because then they can get scarring. You can apply pressure versus scratching. Wear gloves, especially at night, to help the child not scratch, and definitely keep them home until all of the lesions are dry crusted. Reye's syndrome. So this is an acute metabolic encephalopathy that can cause liver dysfunction. It occurs in 5 stages, and as I've mentioned previously, it is associated with aspirin use. The incidence has decreased dramatically because parents are now aware that children with flu-like symptoms and chickenpox should not be given aspirin or even non-aspirin containing salicylates. Something like Pepto-Bismol is a non-aspirin containing salicylate. Teach parents to avoid these. It is treating according to the stage and the signs and symptoms. In general, as a nurse, know that it is very critical for a child that has Reye's syndrome to do good neuro assessments and maintain an accurate intake and output. Why do we use a cool mist vaporizer? Remember, we're always thinking about the safety of these children, and cool mist is much safer than a hot mist. Pertussis, also called whooping cough. Here, the transmission is direct contact and droplet spread from an infected person. Also, indirect contact with freshly contaminated articles. The incubation period is 6 to 20 days, usually 7 to 10, but you want to err on the side of safety. Period of communicability, it's greatest during the catarrhal stage before the onset of paroxysms. Clinical manifestations, the catarrhal stage. This begins with the upper respiratory infection signs and symptoms, like coryza, which remember is just a fancy way of saying a runny nose, sneezing, lacrimation or watery eyes, a cough, and a low-grade fever. Symptoms continue for 1 to 2 weeks, and then a dry hacking cough becomes more severe. Next is the paroxysmal stage. The cough here is most common at night and consists of short, rapid coughs followed by sudden inspiration associated with a high-pitched crowing sound or whoop, and that's why it's called whooping cough. During paroxysms, the cheeks can become flushed or cyanotic, the eyes can bulge, and the tongue can protrude. Paroxysms can continue until the thick mucus plug, which is causing it, is dislodged. Vomiting actually often occurs following an attack. Generally, this stage lasts about 4 to 6 weeks, and it is then followed by the convalescent stage. Infants under 6 months of age may not actually have the characteristics whooping cough, but they will have difficulty maintaining adequate oxygenation with the amount of secretions that they have, and they often will vomit mucus and formula or breast milk. Pertussis may occur in adolescents and adults with varying manifestations. The cough and whoop may be absent. However, as many as 50% of adolescents may have a cough up to 10 weeks. Additional symptoms in adolescents include difficulty breathing and post-tussive vomiting. Therapeutic management and complications. This is preventative. Remember, everything that we just talked about, with the exception of Rye syndrome, all have vaccinations, and it's super important to make sure children get adequate vaccinations. So again, here, making sure that they get vaccinated. Therapy is antimicrobial therapy. So erythromycin, clarithromycin, azithromycin are commonly given. Supportive, so they may be in the hospital. This often can be required for infants, also for children who become dehydrated or are having complications. They may have an increased need for oxygen, and we will want that to be humidified oxygen. Make sure they have adequate fluid intake. Sometimes they are in intensive care and on a mechanical ventilator. This you're going to see more often in infants under 6 months of age. Some complications. Pneumonia, this is the usual cause of death in younger children. Atelectasis, otitis media, seizures, hemorrhage, weight loss, dehydration, hernias, umbilical and inguinal, because of such strong coughing, these can occur, and even a prolapsed rectum. Complications reported among adolescents include syncope, sleep disturbance, rib fractures, incontinence, and pneumonia. Nursing care, again, maintain isolation during that first catarrhal stage. If the child is hospitalized, make sure you're instituting droplet precautions. Obtain nasopharyngeal cultures for diagnosis. Encourage oral fluids. Offer small amounts of fluids frequently. Ensure adequate oxygenation, especially during those paroxysmal periods. Position infant on the side to decrease opportunities for aspiration, especially if they are coughing a lot and then they have that post-tussive vomiting. So that would be why you want them on their side. Provide humidified oxygen, and then suction as needed to prevent choking on secretions. Monitor for signs and symptoms of airway obstruction. Here you would see things like an increase in restlessness, apprehension, retractions, and cyanosis. Encourage the family to be compliant with antibiotic therapy for the household contacts. Encourage adolescents to obtain pertussive Tdap booster. What this does is this not only helps to prevent them from getting sick, but if they're around infants under the age of 6 months of age, it also helps to prevent, if the adolescent gets sick, from giving it to somebody else. So we really want to help to prevent pertussis and spreading it. So that is how you prevent it, making sure you get the vaccine. Also, all pregnant women in their later trimester are also now getting a Tdap with every pregnancy to help prevent the infant from getting pertussis. You want to use standard precautions and masks in healthcare workers exposed to children with a persistent cough and a high suspicion of pertussis. Scarlet fever. This is a group A beta hemolytic strep problem. Source usually is from nasopharyngeal secretions of an infected person and carriers. Here the transmission is direct contact with an infected person or droplet spread, or an indirectly by contact with contaminated articles or ingestion of contaminated milk or other foods. The incubation period is 2 to 5 days with a range of 1 to 7 days. The period of communicability is typically during the incubation period and clinical illness, about 10 days. During the first 2 weeks of carrier phase, although it can actually persist for months. Prodromal stage. Here they have an abrupt high fever. The pulse is increased out of proportion to the fever. Remember, your pulse can go up when you do have a fever. Vomiting, headache, chills, malaise, abdominal pain, halitosis, enanthema, enlarged tonsils, edematous, reddened, and covered with patches of exudate. So that's what that is. In severe cases, the appearance resembles a membrane seen in diphtheria. The pharynx is edematous and a beefy red. During the first 1 to 2 days, the tongue is coated and papilla become red and swollen. So here, unlike Kawasaki's, which is a red strawberry tongue, this is a white strawberry tongue. By the 4th or 5th day, the white coat sloughs off, leaving the prominent papilla. Now you have a red strawberry tongue. The palate is covered with erythematous punctate lesions. Exanthema, the rash appears within 12 hours after the prodromal signs. And here you're going to see a red pinhead-sized punctate lesions. And they rapidly become generalized, but they are absent on the face, which becomes flushed with striking circumoral pallor. The rash becomes more intense in the folds of the joints. And then by the end of the first week, desquamation begins. So you will see a fine sandpaper-like on the torso and sheet-like sloughings on the palms and the soles. This may be complete by 3 weeks or longer. And there is a picture of this in your textbook. So treatment, the full course of penicillin or erythromycin in patients that are penicillin sensitive or oral excuse me, cephalosporins will be given. Antibiotic therapy for newly diagnosed carriers, and these are people that have nose or throat cultures that are positive for streptococci. Supportive care, rest during the febrile phase, analgesics for sore throats, antipyretics for the rash if they are bothersome. Complications include peritonsillar and retropharyngeal abscess, sinusitis, otitis media, acute glomerular nephritis, and acute rheumatic fever and polyarthritis, although that is uncommon. Here you want to institute standard and droplet precautions until 24 hours after the initiation of treatment. Ensure compliance with oral antibiotic therapy. Intramuscular benzathine penicillin may be given. Encourage rest during febrile phase. Provide quiet activity during the convalescent period. Relieve discomfort of sore throat with analgesics, gargles, and lozenges. Know that you don't want to give lozenges to children under the age of 3 for fear of aspiration and choking. You can also use antiseptic throat spray and an inhalation of cool mist. Encourage fluids during the febrile phase. Avoid irritating liquids such as certain citrus juices or rough foods like chips. When the child is able to eat, begin with a soft diet. Advise parents to consult the practitioner if a fever persists after the beginning of therapy, and discuss procedures for preventing spread of infection. Make sure when they're on antibiotics that after at least 24 hours, you will discard their old toothbrush. Also, avoid sharing drinking and eating utensils. Another contagious condition is enterobiosis, also called pinworms. This is the most common helminthic infection in the United States. Here, the transmission is the eggs can be inhaled or carried to the mouth by the hand. So this is why we're always saying, wash your hands and don't put your hands in your mouth. The eggs can hatch in the upper intestines, and the females will lay the eggs out of the anus. So the signs and symptoms: intense perianal itching, increasing at night. This is the principal symptom. So evidence of itching in young children will include irritability, restlessness, poor sleep, and bedwetting, distractibility, and a short attention span. Perianal dermatitis and excoriation can occur secondarily due to the intense itching. If the worms migrate, you can actually see vaginal and or urethral infections. Diagnosis: here they will do a tape test. You will place a clear tape that is wrapped around the end of a tongue blade with the sticky side out. This will be placed at the anus very early in the morning, before the bath and before they've had a bowel movement. Place it in a plastic bag or in a glass jar and take it to the doctor's office so they can do a test. Treatment typically is parental pamoate for children 2 years old and older, and you do a repeat dose in 2 weeks. Side effects include dizziness, headache, cramps, nausea, vomiting, and diarrhea. Albendazole can be given to children under 2, and it is repeated in 3 weeks. Over 2, you may repeat in 2 to 3 weeks. Side effects include abdominal pain, nausea, vomiting, dizziness, headache, increased intracranial pressure, and increased liver enzymes. It is more effective if it is taken with a high-fat meal. Previnium pamoate, here you must repeat the dose in 2 weeks. This medication can cause stool and vomit to be a bright red color and will stain the clothes and skin. Again, you need to repeat this dose in 2 weeks. Follow-up. Treat all people in the home at the same time, as it is easily transmitted. Wash hands before and after eating and toileting. Wash fruits and vegetables well. Keep hands out of the mouth and do not share linens and towels. Please feel free to read the table regarding intestinal parasitic disease on page 174. Impetigo contagiosa. This is a highly contagious skin infection, usually on the face, mouth, neck, hands, and or extremities. It can be caused by staph, strep, or both. Signs and symptoms include burning and itching that develops into a reddish macule that becomes vesicular, which erupts and develops a honey-colored crust. Treatment: apply topical antibiotics like mupirocin or a triple antibiotic ointment for 5 to 7 days. Depending on the severity, they may need oral or IV antibiotics like penicillin if it's severe, vancomycin if it is an MRSA. This is contagious until 48 hours after antibiotics have been started. Follow-up, making sure that the families understand how to apply the medications. You need to soak and wash the crusted areas with an antibacterial soap and then apply the medication. Wash all clothes and linen separately in hot water that a child has contacted. Do not share towels with the child. If they go to daycare, inform the daycare so that they can clean all the toys and the surfaces this child has come in contact with. Dermatophytosis. This is a fungal infection, also called ringworm. There is a picture of this in your textbook. This is a fungus spread from person to person or animal to person. So if you've seen a dog with mange, that is ringworm. You can also get this from seats with headrests and mats. So tinea capitis, you could have the ringworm on your head. Tinea corporis is on your body, and tinea pedis is on your feet. Signs and symptoms: itching, circular patches that are scaly, and these are like sort of pink and red swollen areas. If it's on the head, the hair is lost on that spot, it will regrow. Treatment: antifungal creams times 4 weeks. You can use a selenium shampoo for 8 weeks. Oral grisofulvin can also be given for 8 weeks, and you want to give that with a high-fat food to increase absorption. Know that some of the side effects are headache, GI upset, fatigue, and insomnia, and its photosensitivity. Foot care: you want to keep the feet clean and dry. Use cotton socks and wear shoes that are well ventilated. Inform the child and parents that the hair will grow back in about 6 to 12 months. You want to pat the skin dry. You do not want to rub the skin where the lesions are located vigorously. Vigorously drying can actually cause the itching to worsen. Scabies. This is a highly contagious infestation of mites transmitted by prolonged personal contact. Here you will see small grayish-brown thread-like burrows of mites. They are very itchy, which worsens at night. You can see a black dot at the end of the burrow. And ultimately, what you're going to see is an irregular shaped rash. Typically, the rash is in the creased areas of the body. In children under 2 years of age, often you'll see it around their ankles and feet. And kids in over 2 years of age, you'll see it more on their hands and wrists. Treatment is a one-time application of a 5% permethrin, also called elamite, for 2 months and over. You want to apply this after a bath, and you want to leave it on for at least 8 to 14 hours and then wash it off. It is not uncommon for people to take their bath or shower at night, apply the cream, and then wash it off the next day. All family members and others in close contact with the child should be treated at the same time because this is so contagious. You want to change the sheets and wash clothing and place all non-washable items in a plastic bag for 4 days. It takes anywhere from 2 to 3 weeks for the rash and the itching to disappear. Antihistamines and topical corticosteroids can be applied for the itching. Pediculosis capitis. This is your head lice. This could be transmitted with direct or indirect contact. Here, signs and symptoms include itching. The nits will stick to the hair shaft, so you can see like a little white dot that's on the hair. And there is a picture of this in your textbook. The bugs are often not seen because they avoid the light. So when people are doing the assessment, they will run from the light. The distribution, often we see this behind the ears, the top, and the back of the head. Here they will be treated with a NYX shampoo or a 1% permethrin shampoo. Here you might need to repeat the shampoo in 7 to 10 days. This is contraindicated for those with allergies to ragweed or chrysanthemums. You want to remove the nits with a fine-tooth comb or tweezers. And to aid in the removal, you can use a solution of 50% vinegar and water to rinse before combing the hair through. Follow-up. Wash the clothes and bedding in very hot water and place in the dryer for at least 20 minutes. Thoroughly vacuum carpets, pillows, and furniture. If you are unable to do this, place items that you can't do this with in a plastic bag for 14 days. Lice can live 48 hours off of a person, and then the eggs can hatch 7 to 10 days later. That's why you need to place items in a bag for such a long period of time. Soak combs, brushes, and hair accessories in lice-killing products for at least an hour, or you can boil them for 10 minutes. Avoid using other people's hair accessories and expect children regularly. Know that this is not because a child is dirty or poor. This occurs in all socioeconomic groups. Next, we're going to talk about diaper dermatitis, which is in chapter 10. Diaper dermatitis, the peak age is around 9 to 12 months of age. It's more common in bottle-fed babies than breastfed babies. It's caused by prolonged and repetitive contact with an irritant such as urine, feces, soap, detergents, ointments, and friction. Signs and symptoms include erythema in the perianal region and possible excoriating and progressing to macules and papules, which forms erosions and crust. Moisture in the diaper area creates an environment favorable for a Candida diaper dermatitis. Here with a Candida diaper dermatitis, you will see a beefy red perianal region with satellite pustules. So here you might see red dots surrounding the main area that is inflamed. Treatment. It's best to prevent diaper dermatitis. Change the diaper as soon as it becomes soiled, so at least once during the night. Keep the skin dry. Use the super absorbent disposable diapers to reduce skin wetness. With mild soap, you want to rinse and clean the diaper daily. Change the diaper, I beg your pardon. Each time you change the diaper, you want to use a mild soap and rinse them well. If you are using cloth diapers, use only overwraps that allow to circulate. Don't use the plastic pants over the cloth diapers. Expose healthy or only slightly irritated skin to the air. We do not do heat lamps. Just expose it to the air to let the bottom dry. You can apply ointments such as a zinc oxide, A&D, Desitin, or petrolatum to protect the skin, especially if the skin is very red or has moist open areas. When they are soiled, wipe off the top layer of the ointment and reapply. To completely remove the ointment, remember we don't want to vigorously scrub this very irritated area, especially the zinc oxide. You can use a mineral oil to remove it. As I said, do not vigorously scrub this area. You want to avoid overwashing the skin Also, don't use perfumed soaps. Use diaper wipes that are alcohol and detergent free. You don't want to use anything that has alcohol because they can be very, very irritating. Be very cautious with wipes, so read the label. You may use a moisturizer or a non-soap cleanser like a cold cream or a Cetaphil to wipe urine from the skin. Gently wipe stool from the skin using the water using mild soap. You may also use cornstarch, but please do not use talc. If it doesn't start to heal within 3 days, notify the doctor because it could be a candida infection, which requires treatment with nystatin or clotrimazole cream. If using cloth diapers, make sure you wash them in hot water and in mild soap, and then you do a double rinse using a 1/4 cup of vinegar in the last rinse. Atopic dermatitis, also known as eczema. This is a chronic superficial inflammatory skin disorder. It especially occurs in families with a history of allergies and asthma. 3 forms of eczema include infantile, which usually begins at 2 to 6 months of age and generally undergoes a spontaneous remission by 3 years of age. Signs and symptoms include exudative, crusty, papular, vesicular, and erythematous lesions on the cheeks, scalp, forehead, arms, and legs. These are very, very itchy. Childhood could follow in the infantile form, or it doesn't have to. It can occur anywhere between 2 to 3 years of age. 90% of children with atopic dermatitis will get the signs and symptoms by the time they are 5 years of age. They include symmetric involvement, erythematous, dry, scaly, well-circumscribed, papular, and more thickened and lichenified pruritic lesions on the wrists, hands, neck, and anacubital, as well as the popliteal fossas. Adolescents and pre-adolescents, here the signs and symptoms can begin at 12 years of age, and they may continue into early adulthood or indefinitely. Much the same as childhood eczema, they can have large plaques that are thickened and lichenified on the face, neck, back, hands, feet, and upper arms. The diagnosis is based on the history and physical as well as the above presenting signs and symptoms. 4 goals of treatment: relieve the itching, hydrate the skin, reduce inflammation, and prevent infection. So relieving the itching, you can do colloid baths, which will include 2 cups of cornstarch in a tub of lukewarm water. You don't want to sit in there longer than 20 minutes because that can be very drying to the skin. Using a cool wet compress, avoid wool or constricting clothing. You can use antihistamines such as hydroxyzine, diphenhydramine, Claritin, or Allegra. Wear loose cotton clothing. Avoid foods that increase flare-ups. Also avoid perfumed or scented soaps or lotions because they can also cause itching. Hydrating the skin. Here you can use a dry method of bathing, which is infrequent, and the skin is cleansed with a non-lipid hydrophilic agent like Cetaphil. Wet method baths occur up to 4 times a day with no soap, or very mild soap like Dove or Neutrogena just once a day. A lubricant is applied while the skin is still damp. Oil or oatmeal baths with a light drying may also be done. Glycerin-based lubricants like Eucerin should be applied within 3 minutes of bathing at least 2 to 3 times a day. Avoid hot water as it is very drying to the skin. You also may want to use a humidifier in the home to keep the skin moist. Pat the skin dry. Do not rub the skin. Reducing the inflammation can occur by using steroid creams that can be applied to decrease the inflammation, and this can also be applied prior to the lubricant. Don't use bath additives such as baking soda, bubble bath, or bath oils. Infection prevention, keeping the fingernails clean and short. Infants may actually require elbow restraint to prevent itching, or you can even put socks or gloves on their hands. Oral antibiotics may be required if they develop infections. Please reassure parents that infections don't develop, or infections may develop, but the lesions do not cause scarring unless they develop that secondary infection. So the lesion alone on the face is nothing to worry about unless it develops a secondary infection. So we do strongly recommend putting those gloves on because we don't want them scratching the lesions, which can then again cause issues with scarring. Pimecrolimus 1% cream or tacrolimus 0.03 or a 0.1% is a topical immune modulator used to relieve itching and redness for kids 2 years old and over. Some side effects include warmth and burning at the site, headache, cough, sore throat, and rarely viral skin infections. This is usually used for 6 weeks. If it is not effective, then it is stopped. And typically they stop using this when the symptoms disappear. Lastly, we will talk about acne. This is in chapter 16. Acne is a skin condition associated with increased production of sebum from sebaceous glands during puberty. Acne is a disease that involves the pilosebaceous follicles, the hair follicle, and the sebaceous gland complex of the face, neck, chest, and upper back. 3 pathophysiological factors are involved: excessive sebum production, comedogenosis, and then the overgrowth of P. acnes. Comedogenosis is the formation of open comedones or closed comedones. 70% of girls develop premenstrual flare-ups, which suggest a hormonal cause. Treatment. The goal is to prevent infection and scarring and decrease psychological distress. Tretinoin or retin-A interferes with the development of microcomedones. You want to use this at night because it causes it can cause sun sensitivity, and then you can end up with a sunburn. So please make sure you use this at night, and then you want to make sure that you use sunscreen every single day. You don't need a lot of this, so it's just a small pea-sized amount 20 to 30 minutes after you have washed your face. This also helps to improve the penetration of benzoyl peroxide and other topical antibiotics. So if you are using more than one medication, apply the retin-A first. Benzoyl peroxide. This kills the P. acnes and can be used alone with mild acne. As the skin gets used to the medication, you can increase the strength. Note that this can bleach fabric and also lighten hair. Topical antibacterial agents like clindamycin, erythromycin, metronidazole, azelaic acid, and a combination of either benzoyl peroxide and erythromycin or benzoyl peroxide and glycolic acid can all be utilized. Again, if they are taking oral tetracycline, this can cause sun sensitivity, so please avoid sun exposure. Oral contraceptives can be used for females. This decreases the endogenous androgen production and decreases the bioavailability of circulating androgens, which can help to decrease acne. Isotretinoin. We used to sell Accutane in the United States, but it no longer is sold here. Now you will see Clarivis, Amnestine, or Sortret. It is isotretinoin generically. This is used for resistant severe cystic acne. It can decrease the sebum production to almost undetectable levels. You should not get pregnant while taking this for at least 1 month after the medication is stopped because of the risk of major birth defects. Girls must sign the I pledge. Side effects include dry skin, dry mucous membranes, dry eyes, nasal irritation, decreased night vision, photosensitivity, bone pain, headache, mood changes, depression, and suicidal thoughts. As a nurse, you want to tell the patient that it might take 4 to 6 weeks to begin to see some improvement. Know that they might look worse before they look better because with many of these treatments, the skin will be red, dry, itching, and peeling. If they develop scars, know that they can be fixed with laser treatment and light chemical peels. Dapsone gel is a 5% gel that is effective for inflammatory acne lesions, and this might be used topically with retinoids. Again, here you're going to apply a pea-sized amount twice a day. So this is different than the retinol, the retin-A, which typically is just applied at night. Some side effects include redness, peeling, dryness of the skin. The skin actually might turn a little yellow-orange when it is used with a benzoyl peroxide. The patients need to be taught to wash their face very gently twice a day. Do not vigorously scrub the face. Also, do not use antibacterial soaps. They are too drying in combination with all of the other medications. Avoid astringents because they are irritating and drying. Do not pop or pick at the skin. Avoid oil-based cosmetics and cleansers. Keep hair clean and off the face to avoid forehead breakouts. Anybody, females that are using isotretinoin, they need to be on 2 forms of birth control. One is typically either an oral or injectable, as well as a secondary like condoms. It's very, very critical that this person does not get pregnant. And when the doctor does the monthly renewal of the medication, know that they will do a pregnancy test on this person every single month. This concludes the lecture addressing the behavioral objectives for week 4. Please be sure to read your textbook and complete all assignments for this week to facilitate the utilization of this content and applying it to the nursing practice. Thank you and have a good day.